Now, this is a category that really takes you to a whole nother level of being a personal injury doctor. This is black belt stuff. This is material that you become the absolute authority with the attorneys you're working with. And it's how basically it's teaching them the value of the case. But remember, they don't know the value of they have a vague idea. Remember, most attorneys will look at property damage, an MRI, and whether there was surgery, and that kind of gives them an idea if they think they have a decent case or not. They don't know all the minutia. They don't know all these steps that we keep talking about. And when you put it together, unbelievably, it's unbelievably powerful. As an example, I had an attorney contact me, and it was just off the internet. He saw my videos on the internet and he liked what he saw. And he asked if I thought I could help his one client. Excuse me. If I could help this one client that he had that was in this severe auto accident, and they just kept going round and round in circles and couldn't seem to get anything together. So I said, let's take a look at the case. I got a little bit of the history, and I said, yeah, again, remember, the history is 75% of the diagnosis. So he told me the history, and I said, yeah, sounds like he probably has this. I told him what positive test he probably had, or objectively what he probably had, hybrid test. I told him. I said, I just don't know the severity of it. I said, this is probably everything that's going on. So we sent them over to a local doctor to have all these tests done. He comes back and it was exactly right. Everything I said was right. And now we had everything quantified and we knew the severity. Now, this was after that patient had gone to the hospital, gone to a local GP, gone to a chiropractor, and pain management. Went to 4 different, in other words, it went to all of those people before I lined him up on what probably is happening and what he should do and what test he should do. And none of them were done. So that's what this does. Understanding these factors we're getting ready to go into right now significantly give you authority and with the attorney, because remember, it should be you telling the attorney how strong of a case he does or does not have. It should be you. They don't know the minutia. They don't know the medical. They just have a few big ideas. Was there a lot of property damage? Was there surgery? Was there a positive MRI? And even when they have those cases, they still aren't real clean in how to layer the case like what we do. And so this is when you become a real authority. Now, when I say real authority, what does that mean? It means you're going to get all of the referrals. Their attorney friends are going to hear about you, and you're going to get all their referrals. And chances are you're going to be asked to testify in court more often. In other words, you're going to get a lot of business. So if you want to be known for personal injury in your attorney in your area, there's all the documentation you need to know, blah, blah, blah. But the end result is when you can explain to the attorney what I'm getting ready to go over with you right now. And what it is it's a combination of the categories. What are the bare minimum categories that you would need to stop a unfair bad faith offer and to move it into a high value case? What are the bare minimum categories of documentation you would need? Okay. And remember, we're always evaluating this as if every case is going to go to court. So that's how we're evaluating this. And then we have to look at some diagnostic factors. We have to look at this data. So these are major factors to consider with evidence. Okay. So first, let's go into the 7 major categories. Now, we already know that there's 12 major categories when you write out your narrative report to tell the story to support the injury award. Okay. So we already know there's mechanism of injury, injury magnifiers, subjective evidence at MMI, hybrid evidence at MMI, objective evidence at MMI. What was the therapeutic protocol based on the test and the science of the three phases of healing? What was the response to treatment? What were the complicating factors? That takes them to MMI. That takes them to the impairment rating and the impairment indexes. That takes them to the prognosis and need for future care. And then last is apportion any pre-existing injury. Now, we already know those 12 major categories. Are all 12 of those categories absolutely necessary to shift a case? That, in other words, to have all of those necessary to move to create a high value case? And the answer is no, no. The bare minimum categories you would need is mechanism of injury. That's a bare minimum. Do you need injury magnifiers? No, that's just icing on the cake. Do you need subjective evidence at MMI? Yes. If you don't have subjective evidence at MMI, you better have a really unique case for it to create any kind of value. Is there hybrid evidence at MMI? That's an important category. And is there objective evidence at MMI? Those are the three big ones: subjective, hybrid, and objective. Now, how important is therapeutic protocol relative to the injury award? Not the patient. See, remember, we're differentiating the patient versus the injury award. Well, it's not relevant at all to the injury award, the therapeutic protocol. Is the response to treatment relevant? No, it's not. Are the complicating factors relevant? No, it's not. I'm talking bare minimum stuff here. Would it be helpful if we had those? Yeah, but are they needed? No. Is it important that they reach maximum medical improvement? Definitely. They have to have. That's major. That takes us to the impairment rating. So once they're finished with the three phases of healing, that allows us to go to the impairment rating. We know that they've healed wrong permanently for life. That's what MMI tells us. Then we go to the AMA guides to get the impairment rating and use the impairment indexes. And that takes us to the prognosis and need for future care. So those are the 7 most important categories. Apportion pre-existing injuries, not that important. I mean, it's important in the scheme of everything, but is it, a single major factor that I need to definitely have that category to support the case and take it out of an unfair, bad faith, lowball offer to a high value offer? No, no. So be familiar with the differences here. So I'm not saying that these factors that I've not included are not important. That's not at all what we're saying. But do we need injury magnifiers, therapeutic protocol, response to the treatment, complicating factors, and apportion the pre-existing injury? Do we need those definitively to be able to stop a lowball offer and or stop an unfair, bad faith lowball offer? No. No. Now, clinically we do, but that's not the bare minimum of what we need. So the bare minimum are those 7 categories. Mechanism of injury. Yeah, that's the financial liability. And then you better have subjective, hybrid, and objective evidence as a bare minimum. And then there's the medical MMI that takes you to the permanency, and then you got the impairment rating and the need for future care. So there you go. I've got everything I need if I have the bare minimum in these categories. And then remember, when we say bare minimum, what are we talking about? Well, let's go to the top category here. You go, okay, these are the major factors to consider with evidence to support an injury award. In other words, when I talk to an attorney and I look at the evidence, now I'm talking about not just my evidence, but say I was hired as an expert witness. I have to evaluate that evidence, and I have to put it through a filter. And this is the filter I have to put it through. Is it primary evidence? What's primary? Is it directly related or is it the diagnosis? That's primary. And primary can change depending on the injury. If you got one injury, you can have one test that's primary for that injury. And then you can have a total separate injury. And now that test is not primary at all for that other injury. Maybe it's not even secondary. Maybe it's just a throwaway test. And so we're just trying to say, be aware of the relevance. This is like fluid in motion. It's not just remember A, B, C, D, and that's it. So you got to think of the injury if something is going to be primary. First, you got to know what primary is. Primary is directly related to that injury, and it usually gives you the diagnosis. That's the importance of primary. Secondary, it's indirectly related, and it typically would not give you the, in other words, if you just had the secondary evidence, it wouldn't give you the diagnosis of this other problem. See, these can be switched depending on the injury. Same evidence that was primary in one injury could be secondary in another injury. And we're gonna go into this and give some examples. So you just start thinking in terms of what's important and not. And here's why we want to do that. When you're going over your information with the attorney, or when you go and do a financial driver analysis, you need to know the most important categories first. Does he have as a bare minimum diagnostics in these 7 categories? That's the bare minimum he has to fulfill. And then when you look at those categories, does he have at least primary evidence in each one of those categories? Because that's the bare minimum you need. Primary evidence in each one of those categories. That's the bare minimum. And then everything else helps. It helps if I have 2 primary pieces of evidence in each of those categories. It helps if I have 3. It helps if I have 1, 2, or 3 primary evidence, and now I have a secondary. Then it helps even more if I have 1, 2, or 3 primary, and I have 1, 2, or 3 secondary pieces of evidence that supports that injury. See, it just keeps getting bigger and bigger within that same category. And then the ultimate is, do I have multiple different diagnostic categories that are primary? So it helps if I have 2 totally different diagnostic categories that are primary within one of these categories. So that's the hierarchy. And so when you're going through and do a financial driver checklist, you've got to look at the data and determine, is this primary evidence? Is it secondary evidence? Is it high versus low sensitivity diagnostics? It's the same thing. High or low sensitivity diagnostics totally depends on what problem we're looking for. So I could have one problem with the diagnostics are high. I can have another problem, the same diagnostics are not only low, they're irrelevant. So we're paying a lot of attention to relevancy, high and low sensitivity. How sensitive is it for that particular problem? And remember, it changes. It depends what the problem is. Now, most of what we're dealing with is the low impact soft tissue spinal injury with pathologically altered spinal bowel mechanics and ligamentous lesions. Okay? So that's going to give us a whole different set of primary and secondary factors. Now, if I had let's say a concussion, all of those primary and secondary factors, or most of them, would change. Okay. So next thing we want to pay attention to is not only if it's high or low sensitivity, is this a high sensitivity test? In other words, I want to be able to tell my attorney, that's an important test. That's a high sensitivity test for this problem, and it's primary. And it's in the objective category. This is a very important test. See, You need to be able to tell your attorneys the difference between these. They don't know. You're the one that puts it together. And that's essentially what happens with the financial checklist. You're going, first thing you're doing is just looking at this, you're looking at all the categories first. Then you're going to look at the 7 major categories. Second, are they fulfilled? Then in those 7 major categories, do they have at least one primary piece of documentation in each of those 7 categories? That's what you're going to look for. And then you're going to see, was there more than one primary piece of evidence over every in in these categories? Because that's going to help the case even more, or not, depending on if it's there or not. But for you to have the ability to explain it is phenomenal. That's exactly who they want to teach, to lead them with these cases, and especially in court. That's the kind of mentality you want. Remember, you should be leading them. They should not be leading you, which is a huge 180 degrees opposite concept with most chiropractors. Most chiropractors still give the lead to the attorney. And I'm talking about clinically. Obviously, the legal part is theirs. But we know clinically what is more important and less important with a case, or at least you should. And so when you have the ability to explain this to the attorney, and by the way, that's what I did in that case. We went in and looked at all the information, and then I explained to them, here's the 12 major categories. Here's the bare minimum 7 that you need with primary evidence. Here's all the evidence you have in each of these 7 categories. In this category, you had 4, like in that particular case, he had 4 objective pieces of evidence, 4, and he had 3 different categories. They were all primary, and they were, in other words, they were directly related to that problem. They were in the objective category, and they were different. Each one of them was a different diagnostic category. That was powerful. That was very strong. And he didn't even know if he had a case at all when he started. See, that's you that's got to share with them, 1, if it is a case, and 2, how good of a case is it? That's you that should be doing it. Okay, so we'll look at not only high and low sensitivity diagnostics, and we'll do a comparison after I go through this. Let's just run through some basic diagnostics and do like a pro and con to kind of help clear it up. So let's go to relevant or non-relevant. Is it relevant? There's some tests that just are totally relevant. What I hate to see is when a doctor does the last MMI exam, and there's no cohesion of diagnostics with that particular injury. You can tell he just stayed remote. He just did his 20 tests that he does for everybody. He didn't move the wagon over to the injury and start dressing that injury out with all the different tests and diagnostics, and moving away from his routine stuff that was totally irrelevant for this case. And matter of fact, it created problems because one of them was positive. I'm like, oh, great. We got a positive test over here that's totally irrelevant. He shouldn't even have been doing the test in the first place. He just did it because he stayed with his routine. So you've got to move your wagon. When I say move your wagon, what I mean, you should already know what the problem is. And you should start zeroing in when you're doing your consultation and exam with specific tests and specific questions relative to that specific injury that you're pretty sure has happened with that consultation. That's what should happen. And even when you do an exam, you should move accordingly. It's like I start doing an exam, and I'm looking at the head, neck, and shoulders, and next thing you know, they're starting to show more shoulder problems. Well, guess what? I'm going to start breaking out more of my shoulder exam. or they start showing some neurological problems. I just do one, or just, as part of the test, just checking the neurology. And they start showing the initial signs of a neurological on maybe one test. Well, I'm now expanding the neurological category of that exam. I'm moving the wagon. I'm not just sticking with my 20 tests. Okay. And that's what happens with chiropractors all the time. They just stick with their test. No, move it to where first focus on to where the highly probable problem is, and then move it as necessary and expand it as necessary, which also means contract it. As an example, this one chiropractor did part of his 20 tests was the patient's low back. Well, if the patient does not have any low back problems whatsoever, symptom, you don't need to be doing a low back. You're in the wrong area. And then especially if you get something down there and now it really is moving everything away from the low back. So you don't just stay in your paradigm. You shouldn't have even been doing the low back. Okay. And I see that a lot. I saw that even with the diagnostic test. The guy he did Dynaram for the neck and low back. I go, why'd you do that? He goes, well, that's just usually what I do. I'm like, that's not the answer you give. The answer is based on the patient. The patient had no problems in their low back. What the hell are you doing a Dynaram on their low back for? And here's the bad news in that situation. It came out positive. So he had no complaints, nothing going on now. He had a positive Dynaram. Now we have to explain that away. It took away from the credibility of the positive finding where the problem was. Okay, so be aware of these things. Okay, so we're talking about high versus low sensitivity, relevant versus non-relevant. There's a lot of non-relevant tests out there for the low impact soft tissue spinal injury. Now, also don't confuse UCR, standard medical care. Now, do be aware of standard medical care versus, okay? Because there are some things you have to do that's considered medically accepted and not malpractice. So be aware of that difference. So probable or not probable, there's a lot of tests that aren't even probable. I mean, what's the likelihood if I do the test, it's going to be, am I going to do 20 different tests that aren't even probable? No, you just, just because they're in my repertoire, I do them. No, move the wagon, focus to the injury, move the wagon. Objective, hybrid, or a separate diagnostic category. That becomes real important. Remember, when you have separate diagnostic categories that have primary evidence of the same problem, what just happened to the value of that case? It significantly went up because it was two different. I'm talking now, obviously it helps if you're in the hybrid category, but the hybrid category of evidence is not as strong as the objective category. So would I like 2 or 3 different diagnostic categories in the hybrid category? Sure. It's going to give way more credibility. If I had a nerve, a muscle, and a range of motion in the hybrid category, sure, I'll take it. But I really want it in the objective category. But if I can get it in both, great. But the preference obviously is always objective first. That's the greatest weight. Now, your attorneys don't think like that because they're attorneys. They're not medical providers. So they don't think that you have 2 different categories of diagnostics pointing to the same problem. They don't think of that as being even much greater and much stronger evidence. They don't think of it like that. They usually don't even know the meaning of it. You're the one that's going to be explaining this to them. And you're the one who should be explaining it to them. You're the doctor. This is how you evaluate cases to determine the strength of the case. So then you have separate diagnostic categories. And then, of course, we would like we would like primary and secondary in all 3 major categories, objective, hybrid, and subjective. but obviously the objective category is way more credible. So what I'd like at least, do I need at least one primary category in the objective category? Yes. Would I like to have two primary categories? Yes. Would I like to have three? Yeah, all of those increase the strength. But I'd also like to have another separate diagnostic category. Now that significantly increases strength when I got two different diagnostic categories saying the same thing or pointing to the same thing, you see. So same with hybrid. We need a minimum of one primary finding that says, yeah, that's pointing to that problem. Is it better to have two? Yes. Is it better to have three? Yes. Does it help if you have at least additional secondary finding? In other words, it supports that there's a problem, but it doesn't say, that alone doesn't say that you have that problem or gives the diagnosis for that problem. That's a secondary problem. And then there's the irrelevant problem. You know, irrelevant, you say you're doing something in the head and neck and he's got a positive SI. Well, that's totally irrelevant to the head and neck pathological spinal biomechanics. See, that's an irrelevant test. I don't like seeing those. Usually when I see those, it's because the doctor just stuck with his 20 test routine. He didn't move the wagon to the centric portion. In other words, narrow everything down to the centric portion and then expand the test accordingly and as necessary. Okay, so having said that, so here's what you need to just consider. You go, okay, when you're evaluating these checklists, go, okay, here's the 12 categories. Out of the 12, here's the bare minimum 7. So if I get a mechanism injury magnifier, fine, but it's not a bare minimum. So do I have at least one primary finding in those 7 categories? That's number 1 right there. Then if there's some of these other categories you have with primary or secondary evidence, great. You know, therapeutic protocol, response and treatment, complicating. You have anything that's directly or indirectly related, fine. But just remember those are secondary categories. And then same with injury magnifiers or portion pre-existing injury. Portion in pre-existing injury is going to be secondary. It's not going to be primary. Okay, so once I go, okay, do I have the 7 fulfilled? What's my next question? Well, do I have at least one primary piece of evidence in each one of those categories? That's the next question. What's the next question? Do I have more than one primary? What's the next question? Do I have secondary evidence within that same category? What's the next question? Do I have more than one secondary evidence within the same diagnostic category? What's the next question? Do I have more than one diagnostic category with a primary finding? Now that's big. So instead of x-rays, now you got Dynarom, or you got x-rays and you got a blood test. Say now you have second. And even if it's secondary, it's still important because it's a different category. So I'm going to pay a lot of attention now. Would I like there to be everything be primary? Sure, but that's not reality. The reality is you're going to have a little bit of everything to some degree. How well you do your diagnostics will determine that. So will we have possibly a little positive findings with palpation and tenderness? Yes. Okay. All right. So having said that, let's walk through some of the basic tests that we would do. And remember, we're going to talk as though it's a low impact soft tissue spinal injury, pathologically altered spinal biomechanics with ligamentous lesions. Okay. Because that will change if it's a disc injury, you know, whether something's primary or secondary, in other words, what's most important is not as important. That changes with the problem. How important is that test relative to that problem? Well, that positive left SI compression test is pretty damn worthless when you're evaluating a concussion. Okay? So that's how you just kind of got to think of these things as in a hierarchical manner, because that's what gives it strength. I call it vertical and horizontal documentation. Vertical and horizontal documentation. What do I mean by that? Horizontal is 1 through 7. 1 through 7, horizontal. I got all 7 categories. Maybe I have primary categories in 1 through 7. Maybe I have, okay, see, now when I go vertical, now maybe I have multiple primary categories. See, so it really is, you got to think of it as vertical and horizontal documentation. It's not just A or B, black or white. You got to, it's kind of like a 3-dimension object. You go, okay, wait a minute, this is 3-dimensional. And that's what's going to determine the strength of the case. So so again, what do you start with? Well, you're going to start with the 12 categories, just have them there, but you're going to narrow it down to the 7. You go, wait a minute, I have to see if I have a minimum of these 7 categories with at least one primary piece of documentation in each one of these categories. That's the bare minimum to have a good case, to stop the unfair, bad faith offer, get to high value. In other words, that's my definition of I'm willing to go to court to testify against this is necessary. That's the definition. That's the criteria right there. I'm telling the attorney this. This is the criteria that I use and how and why. I'm going to feel good if I got all 7 categories and I got primary related evidence in all 7 categories. That's the bare minimum that I need for me to be willing to go to court. I have anything less than that, I don't want to go to court. I want to try to get out of it. I want him to try to get out of it because there's going to be holes. And then the case gets stronger and stronger when you not only have the 7, but now you start having these other categories being fulfilled too, these secondary categories, injury magnifiers, etc. And then you have 2 primary pieces of evidence within the same diagnostic category. In other words, 2 x-rays in the objective category. See, that would be 2 primary pieces of evidence in the same diagnostic category. That's 100% objective. Or like in the hybrid test for the cervical ligamentous lesion. You got a foraminal compression test. Well, I'd consider that primary. When I would have direct compression, I would consider that primary for the ligamentous lesion. When I have distraction positive, I would consider that primary. In other words, it's directly related to that joint and that ligament. Adson's test, well, that's not going to be primary for the ligament. It's primary for nerve. It's primary for brachioradialis. So it would be secondary to the ligamentous lesion injury, secondary. And it would be in the same category, hybrid. See? Okay, so that's how I'm looking at this. So let's walk through the most common categories of diagnostics. And so you go, okay, what about the vital signs? Height, weight, blood pressure. Okay, what about that? So you go, is height going to be relevant in here anywhere? No. Weight could be if they've gained weight, that could be primary. Could be if they've gained weight because of loss of activity due to the injury, which is very common. Now it's a primary factor. It's directly related to them being injured, them gaining weight. See? Height, weight, blood pressure. Blood pressure could be directly related to it. Would I be able to explain to an 8th grade educated jury the connection between high blood pressure and an injury? Sure, that'd be pretty easy to explain. Okay, so that kind of gives you an idea there. Let's go to structural analysis. You're going to look at the patient structures, head tilt, head rotation, shoulder high, low, ribs tilting, okay, kind of a basic chiropractic structural analysis. And then we'd go through and go, is it primary? Well, it could very well be primary. Look at the neck. Are we seeing any structural distortion in the neck? Well, that would be primary. Shoulder heights, I would call that is directly related to the neck problem. If there's like one high or low shoulder, possibly. Ribs, maybe not as much. Hips, no. Arches, no. Is it a high or low sensitivity test? Well, for a ligamentous lesion, it's a low sensitivity test. I'm not going to do an arch support test or check your shoulder heights or to see if you have head rotation. None of those are going to give me a diagnosis of ligamentous lesion. So none of them could be relevant. Okay. And they would be probable. So there's a chance if you'd find something there if somebody hurt their neck. Separate diagnostic categories. So let's go into, and then we'll pay attention to objective, hybrid, and subjective. So let's go into range of motion. And he goes, that primary? Yeah, it can be at MMI at the end of a plane of a range of motion. Maybe one plane at the end of one plane of motion is restricted. That's let's say the neck. Okay. Yes, now that would be primary related. That's directly related to that injury. Okay. Is it a high or low sensitivity? It's a lower sensitivity test for a ligamentous lesion. A lot of times at MMI, a lot of times it's back to 100% normal. Is it relevant? Yeah, it's relevant. Range of motion and the plane of motion and which plane of restrictions? Yeah, that's highly relevant. Is it probable? Yeah, it's probable. It's more likely you're going to find, and again, are you going to find it in all range of motion and all restricted with a low impact range of motion at MMI? No. Is there a chance you'll probably find at least one plane of motion with a little bit of restriction at the end of that plane of motion with MMI? Yeah. Okay. So in other words, you should be looking for these things, not just following your 20-piece exam chart. Focus in on that area where the injury is and do more. And then move the diagnostics to where it leads you. And move away from the stuff that's routine, that's not even relevant. Just don't be a robot in there and do your 20 tests because you do 20 tests. Okay, so let's go into overpressure range of motion. Would that be primary? Yes. Secondary? No, definitely primary. Is it high or low sensitivity? High. Relevant? Highly relevant. Probable? Highly probable. Is it a separate diagnostic category? Yes. Is it objective, hybrid, or subjective evidence? Hybrid. It's a combination of the patient and the doctor's interpretation. See, that's a classic right there. And then you go to joint motion. Well, joint motion is evaluated with x-rays. So we're in the objective category. So and again, it depends on the x-ray. Which x-ray did you do? Well, if you did a stationary x-ray, you have a very irrelevant diagnostic test for a ligamentous lesion. That's just the wrong test. Now, if you were checking for hyper or hypolordosis, you have a primary test for that particular finding. So it's always relative to what you're talking about, each of these diagnostic tests. So again, remember, an MRI can be totally irrelevant, inconsequential to a lot of injuries, a lot of problems, but it can also be extremely highly relevant, primary and highly sensitive to some injuries. So start with the injury. What kind of injury? And that all starts with the consultation, the mechanism of injury. Then from there, you help verify it and quantify it in the physical exam. And then the diagnostics help to verify and quantify it. That's what should be happening. But you should know the difference of what is valuable and what's not if you're doing personal injury. Well, this is what determines what's valuable and what's not. This is how you would explain it to an attorney. I mean, you may have a case that has all 7 categories, right? But you only have secondary findings. You have no primary findings. You're going to have a problem with that case. You're going to have a problem with it. It's a bare minimum. We said those 7 categories with 1 primary category in each of one of those 7 categories, because it justifies that accident happened. He had a chance to heal. There's a permanent injury, and he's going to have problems the rest of his life. That's what those 7 categories say when they have at least 1 primary finding in those 7 categories. That's the bare minimum of a high value case and moving it away from the lowball, unfair, bad faith offer. And then you have everything in between. You go, well, what kind of value do we have? Do we have all 7? How much primary evidence? How much secondary evidence? How many different categories do we have? Is it high or low sensitivity diagnostics? Is it relevant or non-relevant? So let's go into the next category is the ligamentous lesion. Well, we know it's the objective category. Is it primary or not? Well, it depends on what lesion you're looking at and what x-ray you took, like I said. So if you took a neutral AP and lateral, you're not going to see anything for an atlo-atlanto ligamentous lesion. So you did the wrong test. So see, but now you go ahead and do left and right lateral tilting with APOM, and there you go. Now we have a primary diagnostic test showing a primary problem. There you are. That test just changed because of what we're looking at. Is it a high or low sensitivity test? It's high. Is it relevant for that injury? Yes. Is it probable? Yes. Is it a separate diagnostic category? Well, it's a standalone diagnostic category, the x-ray. And it's objective, okay? So same with physiological line of stress. Is it primary? No, it's just an indication of abnormal spinal biomechanics, altered weight bearing. That's what it is. Now, if that's what you were looking for, if you were looking to support a diagnosis of altered spinal biomechanics and weight bearing, then it would become primary. But for the ligamentous lesion, in other words, if you had that problem, it would not be the definition of a ligamentous lesion. If you had abnormal physiological line of stress, it would not mean you have a ligamentous lesion. That's kind of how you look at these and whether something's primary or secondary. If it's primary, it pretty much says you have it, and that's usually the diagnosis. Secondary means it doesn't say you have a particular problem, but it supports that a particular problem in some form or fashion. In other words, something's wrong, and there's a connection here. So that would be an example of physiological line of stress. Go down to, let's go down to the lower back and say left or right lateral bending. That's objective. And let's say we have some abnormal movement motor unit down there. Is that primary? Yes. Secondary? No, it's primary. That's your diagnosis. High or low sensitivity? High. Relevant? Highly relevant. Probable? Highly probable. It's its own standalone diagnostic category, motion x-rays. So let's go into, after that, let's go into muscle strength. So what category is that? Hybrid. Is it primary for ligamentous lesion? No, in other words, because if you just had a muscle weakness, does that mean, if that's all the information you had, that you automatically have a ligamentous lesion? No. Therefore, it's secondary. It's supportive. So if you're going to have a ligamentous lesion, is it highly probable, or can you have muscle weakness? And by the way, when I'm looking at muscle weakness, if I'm not talking about an injury in the neck and they got muscle weakness in their big toe. This stuff has to correlate. So I'm looking at the muscles strength in their neck and bilateral upper extremities. I'm not going to correlate their lower back. You know, that's when you're really off target. And be careful about that. And again, that's when you get those findings, it's because, again, you're sticking to your 20, exam formula instead of doing your regional exams and then expanding on the regional exam as necessary. That's when you get all this weird stuff. And that weird stuff doesn't look good in court, and it doesn't sound good in court. And it's a major distractor. I don't want a positive left SI compression and the person has no lower back problems whatsoever. But I went down there and did an exam and found a finding. I just helped weaken my case for the neck. If I had a good attorney, I'd come down there and exploit it. Okay. So that would be muscle test we talked about. Could it be, now it's primary for muscle. It's not primary for ligamentous lesion. See, that's a classic example. If I have muscle weakness, it's weak. Yes, it's positive for muscle weakness. That's primary. Secondary for another injury, ligamentous lesion. High or low sensitivity? Well, it's high sensitivity for muscle. It can be high sensitivity for ligamentous lesion, has the potential to be. Is it relevant? Yes. Muscle weakness relevant to spinal ligamentous lesions? Yes. Is it probable or not probable? Well, here's the deal with that. And again, if you're doing standard muscle strength test, then it's probably going to be normal. But if you do the high sensitivity muscle test that we teach, in other words, you do the muscle test when you're actually putting your finger on the lesion of the neck, the area of the neck where the lesion is, then you have a highly probable weakness, and it'll be there a lot of times. So that's the difference between high and low sensitivity testing. A doctor who doesn't do that will come out with normal. The doctor who does do that will say, yeah, C5 deltoid is weak as a result of ligamentous lesion, say, or whatever the lesion was, see. Okay, separate diagnostic category. Are we in a separate diagnostic category? Muscle? Yes. So yeah, remember, it's a good thing now we're in a totally different diagnostic category that says the same thing. Even though it's secondary, it directly relates to that ligamentous lesion in the neck. It's primary for weakness in the muscle. So remember, these separate diagnostic categories with primary and secondary evidence significantly help magnify the support value of the case. And then, of course, what category is it in? Well, muscle testing is in the hybrid category. But again, remember, what do I prefer to have? If I were going to court, I want primary and secondary evidence and multiple categories in all of these objective, hybrid, and as many as possible. Those are all the layers that increase the validity and the strength of the case. That's what personal injury documentation and high sensitivity documentation is about. It's about finding all these layers and knowing their relevance. That's what we're doing here. What's the relevance? And this is how you should be able to explain it to an attorney. They don't know any of this that I'm talking to you about, unless it's grossly obvious. So that would take you through the muscle strength, go through the nerves. Typically, the nerves are the cranial nerves, dermatomes, and reflexes. Is it primary? So cranial, let's use the cranial nerves in mild concussion first. It would be primary, yes. Secondary, no. High or low sensitivity. I'd call them high sensitivity to cranial nerves for mild concussion. Is it relevant or non-relevant? It's relevant. Is it probable? It's not probable because remember, it's typically not a physical problem with mild concussions. It's more behavioral. Is it a separate diagnostic category? Yes. If I had, between my normal workup, in addition to that, I had my behavioral studies for a mild concussion that was included in this spinal ligament lesion and all the supportive document. I've got a very, very Very good case. Now we're talking about the brain also. So these behavioral studies with mild concussions significantly help reinforce the ligamentous lesions injuries and the support of that injury award significantly, not a little. So am I going to be paying a lot of attention to the symptoms of a concussion and the diagnostic workup of behavioral analysis from a neuropsychologist or a psychologist that does physical trauma behavioral test? Yes. That's a high potential right there. How about reflexes? Primary, can they be primary? They can be primary, not as necessarily secondary. High or low sensitivity, they're usually high sensitivity. Are they relevant? They're usually not. They're not relevant because they're usually not probable. Usually there's no problems with reflexes in a low impact soft tissue spinal injury. Same with dermatomes. You may have some variation. So could they be considered primary? In other words, really important to a neck trauma injury? Yeah. Secondary? No. Are they high sensitivity? Well, they can be, but they're typically not. They're not typically relevant because they're usually not positive. Probable, not probable. It's not probable. Separate diagnostic category, but you're pretty much never going to get it. I've never had a NCV or EMG come back, even though I'd had a lot of patients with radicular symptoms and positive brachioradialis orthopedic findings, and they still come back normal with the electrodiagnostics. So that's the category. And then if you go into the objective findings, let's say some of the objective orthopedic tests, or excuse me, the orthopedic tests are hybrid. So some of them would be primary. As an example, the neck, pyramidal compression, distraction, compression, those are all directly related to the neck joint and ligaments. Shoulder depression. Shoulder depression would be a major factor. I'm stretching those ligaments. Again, Adson's test, no, it wouldn't be. It would be secondary for ligamentous lesion if it was positive. But if there was tingling and numbness, it would be primary for radiculopathy. See, same with Phelan's or Tenell's. You got Adson's, Phelan's, and Tenell's. Is that primary? If I have a ligamentous lesion, well, I could associate it with as being very important, but just because you have those doesn't mean you have a ligamentous lesion. So I'm going to call them secondary, and they're hybrid tests. Remember, orthopedic tests are hybrid tests, but they're definitely directly related. And we have a separate diagnostic category. See, we got orthopedic tests now. So you see, these things make big differences when these different categories start adding up. So we have a secondary test that's neurological. It's a separate diagnostic category that's hybrid. So it's a pretty important layer. You know, there's more layers that are more important and there's other layers that are less important, but that's a pretty important layer. So after that, there's the orthopedic test. We talked about palpation already, how it relates to these. And then you go to the dynaram, you go primary. Well, dynaram's primary for muscle. Just because you have a positive dynaram test does not mean you have ligamentous lesion. But it's definitely secondary, and it's 100% objective, and it's in a total different category. So this is very good stuff. Another category, secondary, and it's primary for muscle spasm, secondary for ligamentous lesion. High or low sensitivity, that's high. Is it relevant or non-relevant? It's very relevant. Probable or not probable? Highly probable. See? So this is the language. This is the talk. When I go and I'm talking to attorneys and I'm looking at this evidence, I'm just matching the evidence into the 7 categories. I'm matching them in and going, well, is this primary or secondary evidence? Is it high or low relevancy? Or high or low sensitivity? Is it relevant or non-relevant? And blood tests are the same. Is it primary? Is it direct? It doesn't say you have a ligamentous lesion, so we call it secondary, but it's very important. High sensitivity, definitely relevant, definitely probable. It's definitely a secondary test, and it's definitely objective. That's a big deal. Okay, so and then let me just do a contraposition, and in the same way with MRIs, an MRI test is essentially worthless with a ligamentous lesion, especially when they evaluate it stationary. So you have an MRI and it's totally worthless. Is it primary? No. Secondary? No. Is it high sensitivity for that injury? No. Is it relevant to that injury? No. Is it probable? No. It's a separate diagnostic category and it's subjective, but it's worthless for the ligamentous injury. Okay. And then if we were going to look at, we'll finish with the basics of what does the average chiropractor do that's not trained? Well, he'll look at symptoms. Okay, he'll have symptoms. He'll stick with the basic test, active range of motion. Okay, he'll have nothing. Go to neurological category, reflexes, dermatomes, cranial nerves, and MMI. He'll have nothing. Go to, let's see, after there's radio muscle test, muscle test, he'll have nothing. What's the next big category? Orthopedic test. He may have an orthopedic test at MMI. So he may have a symptom and he may have an orthopedic test depending on how well he's good with the science of doing orthopedic tests. Does he know much about overpressure? He doesn't go into overpressure with his orthopedic test. He's not even going to have a positive orthopedic test. And then what kind of x-rays, diagnostics does he have? Stationary x-rays, worthless. Maybe as an MRI and it's worthless. There's your 95% chiropractors right there. There's your cervical sprain strain. And that's the information he gives the attorneys. It's worthless. And now the attorney can only ask for him to cut his bill. That's what's going on in 95, 97% of the PI cases. And that's why attorneys typically also, one of two or three reasons, attorneys don't look to chiropractors for personal injury. Any questions about what I just covered? That was about how to be a black belt. That material I just covered, when you know it, you know how to explain it. And you're doing your financial drivers, whether it's somebody else's case or yours. And you can explain to that attorney, here's the 12 categories that are important. These are the most important 7. You have to have at least a primary in each one of these. And then you go and see what all documentation you do or don't have. How many different categories do you have fulfilled? How many primary categories do you have fulfilled? How many secondary categories do you have fulfilled at each of these 7 categories? And then how many different diagnostic categories do you have fulfilled in each of these 7 categories, with the objective category carrying the most weight? That's what's going to determine the value of your case. And it's like layers of a pyramid. That's what you're doing. You're just layering it. It's like laying down 1 through 7, and then you're going to put layers on it with subjective, hybrid, and objective, and it's going to start building until you get to the impairment and pain and restrictions with activities of daily living. How many layers do you have to get there horizontally and vertically? That's what's going to determine the value of the case. That's what you need to be able to explain to your attorney. Does he have a good case or not, and why? They typically don't know unless it's grossly obvious, with a lot of property damage, positive findings on an MRI or surgery. Outside of that, and remember, the vast majority of those cases don't have any of those. And remember, 80% of all cases are under 20 miles an hour. You're not going to get vast property damage, positive MRIs, and surgery, but you're going to get a lot of problems. And that's called the low impact soft tissue spinal injury. That's where 87% of the business is. There's the deal.